Hello and welcome to TiCME, Time Critical Medical Education. I'm Dr. Nick Taylor. I'm an emergency physician based at the Canberra Hospital, and this talk is part 3 of the Decision, Errors and Cognition series. This is the final part of the tutorial all about errors, and as you know, in the last two we first of all talked about thinking types and how our cognitive processes work. In the second tutorial we've talked about errors and how we define them, particularly cognitive errors and affective errors, and in this final part we're going to try and teach you about how you can avoid errors. So we're going to go through today how do we recognize our cognitive errors, how do we avoid making these errors, and can we teach this approach to other people. Firstly, we're going to go back to System 1 and 2 from the first tute. Remember that when they look in studies at what makes effective decision makers, it's been shown again and again that having a combination of System 1 and System 2 decision making is a trait which is present in good decision makers all the time. And mostly people aren't actively trying to use System 1 and 2. They've just developed decision-making process which use them. And a great example is, for example, when you're in resuscitation bay and you need to make very rapid decisions. Now, as we've seen earlier, System 1, that rapid decisions, can outperform System 2 thinking in some situations. And it sometimes takes, due to the rapidity of patients' decline and the way that they change depending on intervention, that you need to use System 1 to make these rapid fire decisions, and spending a lot of time going through each option may not work in the first instance. But a good decision maker will pause and reflect and then use a logical approach in order to double check, cross check, and use other information to make sure that you continue on the right path. And I think we mentioned earlier about how it's very helpful in a very busy, very messy resus to every 5 minutes or so stop, have a time out, and ask the room whether everyone's got any input, everyone's happy that you're on the right track, and is there any suggestions to move forward. Remember that Type 2 processing is available for external analysis and review, and that's because it's a logical, difficult process which is usually recorded. So the decision to interpret the chest x-ray as a pneumothorax and place the chest tube is usually a Type 2 type of decision, and therefore an error that's associated with Type 2 decisions is usually available for review. Remember that a Type 1 type of rapid emotional sort of decision may not be as visible and may not be available to review. So how do we review these Type 1 decisions? Well, most of the time we actually have to be responsible for catching them ourselves. And these decisions require something called metacognition in order to reflect and evaluate. So, metacognition. Clinicians rely on their cognitive activity to make decisions. We've talked about that in lots of detail. But as we've said, this cognitive activity is difficult to recognize and therefore to change. People who are very good at making decisions tend to use these metacognitive techniques subconsciously and sometimes consciously in order to review their Type 1 decision-making processes. So metacognition is literally thinking about thinking. I know that seems like a very vague psych-style statement, but we'll talk about it now in a little bit more detail. So processes of metacognition might involve that actively stepping back from the immediate situation, otherwise known as de-anchoring. And that situation I've just mentioned in the resuscitation bay of putting a timeout into the process is a great example of that. Metacognition might be that you remind yourself that memory has a huge amount of limitation associated with it. There has been some really great psychological studies done where it's proven time and time again that our brains love to believe in what our memory brings up, but it's very commonly not accurate. So if you remind yourself commonly that your memory may not be accurate, you can avoid the errors that are attached to using memory instead of a decision aid, for example, to make your decisions. You need to start looking at problems in a wider perspective than the obvious, and this clearly gets better with experience. So, for example, the patient who comes in non-specifically unwell with the sore elbows, the junior doctor might look at the sore elbows, start examining the elbows, and think of trauma or an arthritis of the elbow. Remember that this sort of narrow focus involves the representativeness error, where you use only the examples known to you to decide what's going on. As you get more experience, you remember those times when you've seen patients with multi-system disease who present with sore elbows, and you might actually cast your net wider from the outset. You remind yourself of lapses or failures that you have made in the past, and remember that is the availability heuristic. So if you only ever remind yourself of things that have gone well, then it's very hard to find the examples which tell you you're on the wrong path. I think the one that I remind myself of all the time is the time when I was on call as a very junior doctor. I just finished my night shift when I went to a medical emergency call. It was just myself and the medical registrar. We were both should have gone home. There was a patient whose pupils were both dilated. She'd been found unconscious with a GCS of 3. Just been started back on a warfarin 4 days earlier after having an intracerebral hemorrhage, and both of us immediately made the decision that this person was essentially dead, called the family, and didn't do very much else. The team registrar turned up 5 minutes later and said, "Oh, did you guys check the BGL? We started this lady on insulin 2 nights ago." We looked at each other and went, "No." BGL was 0.5. Patient woke up on the end of the needle in front of grieving daughter. Always remember that one. And finally, you need to activate known cardinal rules or caveats which assist in this metacognitive process, called cognitive forcing strategies. I'm getting big on the psych mumbo jumbo today, aren't I? Well, what are cognitive forcing strategies? These are the things that you can put into your clinical practice today which help you to recognize and prevent errors. For example, in your department, you could institute forced decision rule activation. Remember, we've already mentioned that decision rules outperform clinicians almost all the time. So you might make it mandatory that a well score and or XDP is entered into your radiology ordering form before a CTPA is ordered. You might decide that you're going to start a process where all prescribing is done electronically, where the system does not allow you to enter an incorrect dose for a certain drug. You might make it your job to teach and publicize known common errors so that everyone has this as their availability heuristic when they're thinking about, for example, the drunk male with the coexisting head injury who wants to discharge himself at 4 o'clock in the morning. You might make it your job to make electronic information easily and readily available in your department. For example, the apps on smartphones which do calculations for you, or the therapeutic guidelines which basically guide evidence-based approaches to most illnesses. You might finish your history by always going back to your patient and saying, "I now want to summarize and recap, and please, can you add or correct any errors or omissions that I have made?" You might begin, and this one I particularly like, that every time someone gives you an ECG or an arterial blood gas, you put it in front of you You stare at it and then you frown. Frowning has been proven to activate system 2. Instead of the big smile, the bit of the wave, and the tick on the ECG as someone walks past, you stop, you put the piece of paper down on the desk, you frown, which forces you to start thinking in a more logical, structured and sequenced way. And you might say that after seeing this tutorial today, I'm going to teach my colleagues about cognitive errors. That would be great. So, if we are going to go through this system from start to finish about how we are going to recognize and then prevent these cognitive errors, we are going to learn those metacognitive techniques. We're going to acquire the knowledge of the specific cognitive error. We are going to identify the situation in our medical lives where that error is most likely to occur, and then we are going to drop in that special cognitive forcing strategy that helps us recognize and then avoid making that error. I know that seems like a theoretical approach, but I can tell you it does work. It really, once you start recognizing how these cognitive errors start creeping into your daily life, you do have the time to pop in those little cognitive strategies and you do prevent them occurring. Alright, so let's use what we've just learned to put into place a way of developing an accurate diagnosis. So to start with, you want to obtain a complete history. Not the one that you want to take, but the actual history that the patient gives you. And that means no leading questions. That means listening to the end. That means summarizing and recapping. And that means going back to get more information when things aren't making sense. Use this history to generate your initial hypothesis, just like a scientist, and then perform a comprehensive but focused and purposeful physical examination. You are trying to answer now the clinical questions posed by the history and add weight to each of your hypotheses. You are then going to use a systematic approach to obtain the diagnostic possibilities to be considered. You're not going to just guess randomly or keep thinking along the very first thing that popped into your head. You're going to use a systematic approach, a Bayesian style reasoning approach, to check each of your hypotheses. You're then going to take some time to pause and reflect and make sure that you haven't fallen into any error traps. You're then going to embark upon the plan you've generated, but acknowledge that it is always uncertain. There is always a chance that you're wrong, and when information comes up that doesn't match the way you're going, you need to recognize it and go back, see that information in new light and see how it affects your hypotheses, and make sure that that information is passed on to the next people to ensure good follow-up. Trowbridge, in the Journal of Medical Teaching 2008, wrote a list of 12 tips for teaching the avoidance of diagnostic errors, and I think this is a really good list that you can use for yourself and for your colleagues. So first of all, we explicitly describe heuristics. That's those sort of shortcut techniques for decision making, how they affect clinical reasoning. We promote the use of diagnostic timeouts, and that's that taking that time to pause, and in a busy resus it might be 15 or 30 seconds. In your own work you might spend a bit longer. Promote the practice of worst case scenario medicine. Why isn't it these 4 really nasty things when we think it's the simple thing? Let's use a systematic approach to common problems instead of relying on intuition. Always ask why. Teach and emphasize the value of a clinical exam in the right context. Teach Bayesian theory as a way to direct the clinical evaluation. Remember we talked about pre- and post-test probability. And avoid premature diagnostic closure. Acknowledge how the patient makes you feel to try and get rid of some of those affectual or emotional error types. Encourage learners to find clinical data that doesn't fit with the provisional diagnosis. So instead of looking at the information you've got and saying it all fits, I'm happy, ask what doesn't fit, and you might come to a differential diagnosis that's more accurate. Embrace the zebras. Don't chase them around your department forever, however. Encourage people learning to slow down. We reward rapid thinking, rapid decisions, particularly in emergency, but encourage your juniors to slow down and admit your own mistakes, particularly in public, so that others learn that mistakes are common, mistakes are normal, and the best thing about mistakes is that if you notice them, you can prevent bad outcomes occurring. System errors are, as we said, the most common sort of root cause behind the errors that we make, and there is substantial evidence that communication is a really big factor in these system errors. There's also good evidence that communication can be taught and people can improve. Not surprisingly, handovers are one of the most error-prone systems we have in medicine. There is evidence that a structured format handover is better. So maybe a system where everyone gives the same headings when they give a handover. This is the presenting complaint. This is my provisional diagnosis. This is the plan, and these are the outstanding things that haven't happened yet. Team training can reduce many of the communication and other system errors that exist, and we use a lot of low fidelity type sims now to help do this. You don't need to have $5,000 worth of walkie-talkie mannequin to be able to do communication teamwork style simulation. So the summary is, learning to understand your own decision making is the key to becoming a safer and better clinician. Be on the lookout for errors and use metacognition to avoid these. Actively promote decision theory and educate your colleagues as well. It's been my pleasure talking to you today about avoiding errors, and I hope you've enjoyed this series on decisions and errors and cognition in medicine. If you've had any questions, please feel free to email me via the question box below. Thank you once again for listening to TiCME.